Okay, I guess we may as well start, everyone. Hello, everyone. My name is Laz Boros, and I'm the president of the Thyroid Foundation of Canada. I'd like to welcome you to our February public education webinar. Our guest speaker today is Dr. Hernan Franco Lopez, who will be speaking on hypothyroidism and thyroid replacement therapy. Dr. Franco Lopez is an Endocrinology Fellow at Western University in London, Ontario. He completed his medical school at the University of Ottawa and his internal medicine training at McMaster University in Hamilton, Ontario. He has an interest in general endocrinology, in particular thyroid and adrenal diseases. He's also interested in medical education and health advocacy, which are important in the field of chronic disease such as endocrinology. Once the presentation has been completed, Dr. Franco Lopez will answer questions from the audience. Catherine Keene, our administrator, will be acting as producer for this webinar. This means she will be managing the technical aspects of Zoom. Some of our board members will also be assisting. Anista Primachandran will be looking after the Q&A section. Lori Martin will assist us in the chat room. This event is being recorded. A little bit of housekeeping before we begin. Today we are using the webinar functionality of Zoom. This means that you can see and hear all the presenters and chat with other attendees, but your audio and camera are not active, and we will not be using the raised hand feature. Although it appears to have been showing up, so please don't use it. The good news is the Q&A feature is active and you can use it to ask your questions after the presentation has finished. If you have any technical issues during the webinar, please reach out to Catherine via the chat feature. At this point, we are ready to begin with Dr. Franco Lopez's presentation. Thank you.
Okay, so let me see if I can share my screen now. Perfect. Okay, thank you, Laz. So hello to everyone. My name is Hernan Franco Lopez. I'm one of the endocrine fellows at Western University. And I want to thank the Thyroid Foundation of Canada for inviting me to talk today on hypothyroidism and thyroid replacement therapy. So I just want to make sure that my presentation is going to work well. Yeah, perfect. So as I begin, I just want to kind of say I don't have any disclosures for this presentation. I don't receive any honoraria or any money from any pharmaceutical companies. As I described the different therapies that we'll talk about today, I'll try to mention them by generic name as well as brand names that most people know about, but I have no relationship with any pharmaceutical companies, and the purpose of this presentation is for educational purposes only. So today I want to run through a few objectives with you. The first, I'll start defining what hypothyroidism is and then describe some of the symptoms that are associated with it. We'll review the mechanism of how thyroid hormones get produced in our body, and then explain the differences between the different thyroid hormone replacement therapies that we have available in Canada. So that includes levothyroxine, which is sold as Synthroid or Eltroxin. We have liothyronine, which is Cytomel, and then desiccated thyroid extract that in Canada we have the Thyroid brand available. And then at the very end, we'll just go through some of the evidence about the use of a single agent versus combination therapy for treatment of hypothyroidism. And I'll try to emphasize symptom improvement and then safety of these therapies as well. So to begin, what's hypothyroidism? So essentially it's a condition where we have a reduced production of thyroid hormone in our body. So typically it's referred as underactive thyroid. For the most part, about 99% of them are due to problems at the level of the thyroid gland, what we refer to in medicine as primary hypothyroidism. And that can happen for many reasons. Now, for the most part, it's an autoimmune destruction of the thyroid gland that we know as Hashimoto's. Essentially, we have little proteins or antibodies that bind to our thyroid gland. And then over time, it actually starts reducing its function. So we become hypothyroid. We can also become hypothyroid due to irradiation injury through the thyroid gland, while that's willingly, such as in radioactive iodine ablation for people with hyperthyroidism or Graves' disease, where we actually purposely give you a radioactive iodine to essentially burn off the thyroid, or unwillingly. So people have exposures at work with radiation that can affect the thyroid over time. We could also have surgical removal of the thyroid gland, and either total or partial. This is most often the case in thyroid cancer, where we see a cancerous nodule that we take out. Either we take half of the thyroid or the full thyroid, or sometimes in cases of goiter or an enlarged thyroid gland, where just because it's so big, it causes compressive symptoms in the neck, that the only way to resolve those symptoms would be to remove the gland itself. And then in other parts of the country, that's not as applicable in Canada, but in other parts of the world, iodine deficiency as well. If you don't have iodine, which is a substrate for the thyroid hormones, then you develop hypothyroidism as well. But 1% of cases of hypothyroidism are not due to issues at the thyroid gland, but more so at the pituitary level in the brain. And we refer to this as secondary or central hypothyroidism. Now, during my presentation, when I mentioned hypothyroidism, I'm referring to primary or at the level of the thyroid gland. If there's any specific differentiation between the primary or secondary, then I'll make sure to mention that as well. So how common is hypothyroidism? So, estimates from the Canadian Task Force on Preventative Healthcare say that about 10% of Canadians over the age of 45 are affected by hypothyroidism. The prevalence tends to be a bit higher in women than it does in men, especially with the autoimmune hypothyroidism or Hashimoto's. And then we know that Hashimoto's can actually run in families. So whenever we see patients, we see that there's clusters in families that is not only the patient that's affected, but also either a sibling or a parent. And what are the symptoms of hypothyroidism? Low thyroid hormones can actually affect pretty much every single organ in the body. So, and sometimes the symptoms can be quite non-specific. So as a physician, it becomes challenging at times, kind of telling apart if the symptoms that the patients are presenting are due to low thyroid hormone or due to another reason. But just to review, neurologically, people with low thyroid function can actually have low mood or depression. It also causes issues with concentration and memory, and that's something that we often hear from our patients. If it's severe enough, it can actually slow down your speech, and it also causes your reflexes to be slow. When we look at the head and neck region, most patients will also describe some sort of facial swelling. The tongue can actually get enlarged, and you can also have an enlargement of your thyroid gland that we refer to as goiter. At the level of the heart, your heart rate can slow down, and the pumping ability of the heart can also be impaired as well. So the heart becomes less efficient at pumping blood out to the body. From the lung perspective, the breathing rate can also slow down, and people can report shortness of breath, especially when they're doing some sort of exertion. At the level of the gut, the gut motility slows down, so most people would complain of constipation. And women of childbearing age also report menstrual period irregularities. And often we find that that's how we actually find that the thyroid hormones are low. It's because they start noticing that they're missing periods, or their periods are becoming more and more irregular. Poor libido and infertility can also be an issue with low thyroid hormones. Muscle aches and pains and joint pain can also be a symptom, as well as untreated hypothyroidism for a long time can lead to osteoporosis. At the level of the skin, most people feel that the skin is cold and dry. The nails tend to be quite brittle, and then people can lose hair as well. And in general, your metabolism slows down. So that's what actually causes some of the weight gain associated with hypothyroidism. And that also leads to cold intolerance as well as general fatigue. So as we can see, there's a myriad of symptoms that can happen. They don't all happen all at once. Most of the time, the symptoms start coming in slowly throughout the course of several months to years. These are symptoms that other diseases can also have as well. So we use the benefit of having blood work as well to try to piece the puzzle together. So now I'll just describe a little bit as to how thyroid hormones get produced in our body. That will actually help us understand how our therapies that we use will help us feel a little bit better. So this is a picture that I took up from a website. I just thought it explains quite well what the axis actually looks like. So if we start at the top, at the level of the hypothalamus here, the hypothalamus is an area of the brain, and it produces a hormone called TRH, or thyrotropin releasing hormone. The purpose of that hormone is essentially to stimulate the pituitary gland that's also in the brain to produce a molecule called TSH, or thyroid stimulating hormone. And it is this hormone, TSH, that we actually use on our blood work, not only to diagnose hypothyroidism, but also to follow the response to our therapies. And the purpose of TSH, essentially, it goes from the pituitary gland and acts directly on your thyroid gland, and it stimulates it to produce thyroid hormones, T4 and T3. T4 is known as thyroxine, and then T3 is called triiodothyronine, but T4 and T3 are easier to say, so we'll go with that for today. And then those hormones actually go into the cells of whichever organ in the body to exert their metabolic action. So we have this concept of negative feedback in endocrinology, and most hormones have something similar like this. So in the cases of hypothyroidism, we essentially have a low T4 or T3 in our bloodstream. So that's depicted at the bottom of my screen. When we have low thyroid hormones, that actually sends a signal up to the hypothalamus as well as the pituitary gland to try to stimulate productions of their own hormones to try to get the system going. So the hypothalamus is going to produce more TRH, and the pituitary gland is going to secrete more TSH. And this is usually what we find in blood work of patients who have hypothyroidism, is that their TSH levels are high. And basically that tells me as a physician that the pituitary gland is trying to stimulate the thyroid gland to produce more hormone. Now, in cases of a healthy thyroid gland, that increase in TSH is going to lead the thyroid gland to produce more T4 and T3 to actually regulate the levels back to the normal range. Someone who has hypothyroidism, the gland will not be as responsive, so the TSH tends to linger at an elevated level, and then you have low T4 and T3. If the thyroid works well, your T4 and T3 go up into the normal range, everything goes back to normal, the axis will stabilize itself again, and we go back to our baseline. Now, on the other hand, if we have too much T4 or T3, as the case is in hyperthyroidism, then the opposite would happen. So elevated levels of T4 and T3 send a signal back to the hypothalamus and the pituitary gland to suppress production of TRH and TSH, and that signals the thyroid to stop producing as much hormone and the levels come down. We actually use this during our treatment of hyperthyroidism, because if we're giving too much thyroid hormone, then that axis will be intact, and we see that the TSH levels will decrease. So essentially, what we do for blood work is we monitor a TSH level to try to get an idea of what the pituitary response is to the level of thyroid hormone that we're giving. In summary, if your TSH is high, that essentially means that your T4 or T3 levels in the blood are low and you're hypothyroid. Essentially, you need more thyroid hormone. However, if your TSH is low, that tells me that your T4 and T3 levels are high and you're hyperthyroid. That means that you need less thyroid hormone. However, the only exception to that rule is if your hypothyroidism is due to problems at the level of the pituitary gland, or what we call central or secondary hypothyroidism. In those cases, most of the time, the thyroid gland actually works well. It's just the pituitary gland doesn't have the ability to produce TSH. So if I measure it in your blood work, your TSH level is always going to be low. So I cannot use that for treatment. Actually, monitored therapy, you're looking at the T4 levels, more specifically the free T4 levels on blood work. So it doesn't matter how much hormone I give you, your TSH is always going to be low because the pituitary gland doesn't produce it. So then we'll talk about how are thyroid hormones produced in our body. So the thyroid hormones are exclusively produced at the thyroid gland. There is no other organ in the body that will be able to make them. And the thyroid gland itself contains follicles, which is essentially a cluster of cells. And in the middle of those clusters, there's actually a fluid called colloid. And the colloid is where the thyroid hormones are usually stored, and then they're released whenever we need them. The two main thyroid hormones, as we know, are T4 and T3. And those thyroid hormones are actually made up of a protein, which is called thyroglobulin. And thyroglobulin contains tyrosine amino acids. And an amino acid is just basically a building block of the protein. And at specific tyrosine amino acid sites, then we actually put iodine in it. So either 4 molecules or 3 molecules. And that's where the number T4 and T3 come from, how many iodine molecules the protein would have. I mentioned tyrosine here because I've seen sometimes some health products that are advertised as hormone supplements called L-tyrosine. And while it may have some good effects on other things, it's actually not active thyroid hormone. It is a precursor of something that we would need for thyroid hormone production. But by taking tyrosine in and of itself, you actually need an intact thyroid gland that actually works to be able to put those things together. So if you have hypothyroidism, just taking tyrosine is not going to be enough to replace your thyroid hormones that are missing. So this is just a graphic that I've made to kind of explain how things work. So on the left of the screen, we have the blood vessel with iodine molecules in yellow. In the middle, we have the thyroid site in blue. And then on the right, we have the little purple colloid. And then we have TG, which is thyroglobulin. So that's the protein that usually it's in the thyroid cell and that we use as a precursor for thyroid hormone production. I also mentioned TPO, which is called thyroid peroxidase, and that is essentially what takes the thyroglobulin and binds some of the iodine molecules to make the thyroid hormones. The reason why I point these two things out is in autoimmune hypothyroidism or Hashimoto's, we actually have antibodies to these two molecules that actually come up on blood work. So patients might see anti-TPO antibodies or anti-thyroglobulin antibodies that are sometimes elevated. And that basically means that those antibodies are targeting those two specific sites in the thyroid gland. So if we need to make thyroid hormone, our TSH level is going to be high, and it's going to stimulate our thyroid to produce hormone. What that does is actually takes in some of the iodine from the bloodstream into the thyroid cell, and it would slowly diffuse it into the colloid. So we actually generate this concentration of iodine molecules within the colloid itself. So there we have the thyroglobulin in the orange and the iodine in yellow. And then once we have all of that, the TPO can actually put those two together and make the thyroid hormones, T4 and T3. Again, T4 will have 4 iodine molecules and T3 will have 3. But then we need to get this back into the blood vessel so that it can go to the rest of the cells of the body. So it actually gets put into little vesicles within the cell. And when it's time to release them, then they go back into the bloodstream. The ratio of thyroid hormones that we produce in the human thyroid is about 16:1. So essentially the thyroid will excrete more T4 than it does T3. And once the thyroid hormones are in the bloodstream, they're actually not free. They actually get bound into proteins. And the two most common ones are thyroid binding globulin, and globulin is just a fancy word for protein, and then albumin. However, we do have about less than 1% of all of the hormone that we excrete that is actually running free in the bloodstream, and that is the free T4 and free T3. And those are the ones that you actually typically see on blood work when we do it along with the TSH. The bound hormone then is used as a reservoir, and the free hormone is essentially what the cells will use for their metabolic action. So that's what they take in. T4, however, is a prohormone, so it doesn't have any metabolic activity. It has a long half-life, and half-life is, how long does it take for half of the concentration of the hormone to be excreted? And it's about 7 days. So T4 actually lingers around the bloodstream for a while. T3, on the other hand, is the active hormone. So that's actually what the cells would use to use their metabolic action. But it has a very short half-life. It's about less than a day. So, if we excrete only T3, it actually gets excreted quite fast. So the way that the body deals with this is, the T4 can be converted into T3, and that happens inside of the cells that need it whenever they need it. And the way that they do this is by these enzymes called deiodinases. And we have 3 of them, but 2 of them are the more commonly seen, D2 and D3. And the way that the cells use this is actually quite interesting, because if a cell needs thyroid hormone, it can either take some of the free T3 from the bloodstream, or it can take T4 and use deiodinase 2 to remove one of the iodine molecules and convert it into T3 to be able to be used at the cell. However, if the cell doesn't need any thyroid hormone, it actually takes that T4 and using D3 or deiodinase 3, it would remove an iodine molecule from a different site and then cause it to inactivate it. And that's what we refer to as reversed T3. So if it needs it, it puts it into T3 to be used. If it doesn't need it, then it can actually inactivate it to reverse T3. And this is just a picture from a endocrinology textbook, which actually shows the process more visually. So we have the capillary here with the bloodstream, and the free T3 can actually go directly into the nucleus of the cell to be able to be used for metabolism. However, as a T4 can also go in, and then the deiodinase is actually generate this checkpoint that if you need T3, then you go through the D2 pathway. But if you don't need it, then you can go through the DT pathway and create reverse T3 that is not active. And at the bottom of this slide, you actually see that D3 can also remove an iodine from T3 to inactivate it to T2 if we really need it. So how do we treat hypothyroidism? So there are 3 different types of medications available in Canada for the treatment of hypothyroidism. The most common would be levothyroxine, which is synthetic T4. And we know that again as Synthroid or Troxin. But then we have T3, it's called liothyronine or Cytomel. And then we have desiccated thyroid extract, which is essentially animal thyroid that has a combination of T4 and T3. And Thyroid is the brand that we have available in Canada. So let's talk about levothyroxine first. So levothyroxine is a synthetic form of T4. So it's a similar molecule to the one that we produce ourselves. And it comes in single pill doses anywhere between 25 micrograms to as high as 300 micrograms. And then we can essentially mix and match depending on the dose that we need. The typical starting dose for someone who's recently diagnosed can vary between 75 and 150 micrograms per day. And we usually base this on the patient's weight. However, I put an asterisk here because older individuals, we tend to start at lower doses and titrate slowly because we don't want to ramp up their metabolism by giving them too much thyroid hormone at once. Ideally, I tell my patients on levothyroxine to take it on an empty stomach, usually between 30 to 60 minutes before a meal. And then I ask them to try to avoid taking it with other medications that can impair his absorption, such as calcium and iron supplements are the most common ones. And then we adjust the dose every 4 to 6 weeks. As you remember, I said that T4 actually has a long half-life of about a week. So it takes a few weeks before it reaches a stable level in the blood. And then the way that I do my titrations is I use the TSH level. Again, if the TSH level continues to be high, then that means that I need to increase the dose. If the TSH level is low, then I might have been giving you too much at the beginning. I have to back down and give you a lower dose. Once the target dose is achieved, and that means that the TSH is in the normal range, then I don't need to monitor the TSH that often. I can actually back down and do it either once or twice a year. The benefit of levothyroxine is for some reason you miss a dose, you can actually take the extra pill the next day. Because again, this lasts about a week for a half-life. So even if you miss a dose, you can just take an extra one the following day and you'll be fine. The American and European guidelines for treatment of hypothyroidism, they actually recommend levothyroxine alone as the main way to treat hypothyroidism. And they give a few reasons for why that's the main recommendation for them. So one, the efficacy. So we know that it actually works for most people with hypothyroidism. And then we have long-term experience on the benefits and safety of this pill. Levothyroxine came in the market between the end of 1960s and early 1970s. And it's easy to administer. It's only just once a day. And long duration provides some stability in the bloodstream. So again, 4 to 6 weeks before we have to do any single titration. And in general, it's quite an inexpensive medication. So in Ontario, which is where I practice, pills can be average around 15 cents a tablet. But what about those patients with remaining symptoms despite having normal TSH levels? So replacement with T4, such as levothyroxine, to target a normal TSH level makes theoretical sense based on that graph that I showed before. However, we physicians always encounter a subset of patients that remain symptomatic despite having normal TSH levels. So then we have to wonder, okay, so what do we do then? There are some studies looking at this question, and in patients with hypothyroidism that are treated with levothyroxine alone, it's actually been shown that they tend to have higher T4 levels, but also lower T3 levels compared to healthy controls. So there's actually been shown in multiple studies. The question is, we don't know what to do with that. It's quite unclear as to whether or not that has any clinical significance. There's also other studies looking at the activity of the deiodinases, that it varies in different tissues. So in the brain, it's probably going to be different activity than the heart, different activity than the liver, different activity than the gut. So some symptoms may respond better than T4 to others. So then we have other options. So there's liothyronine or Cytomel. This is a synthetic form of T3. In Canada, it's available in 2 doses, a 5 microgram and a 25 microgram dose. And if we use it, it should be administered along with levothyroxine to try to mimic what our normal thyroid gland would produce. So again, a 16:1 ratio. So what that does mean for me is that for every 75 micrograms of levothyroxine, then I would add probably around 5 micrograms of liothyronine or Cytomel. The only guideline that actually has a suggestion or a dosing regimen is actually the European guidelines. And they recommend that if we use liothyronine, that we actually do twice daily dosing. Again, T3 is a very short acting molecule, so it actually the half-life is less than half a day. So breaking it down into 2 might work better. Now, since this is the active form of hormone, it actually requires closer monitoring than levothyroxine. Higher free T3 levels can put patients at risk of irregular heartbeats or arrhythmias and also lead to osteoporosis. So I do not recommend the use of levothyronine on elderly patients, especially those who have heart conditions or pregnant women. The reason is in pregnancy, pregnant women actually require T4 to be able to diffuse it into the fetus. T3 does not. So if we have higher T3 than we do T4s, then that can lead to issues with the baby. So we tend to avoid this in pregnant women. If we use T4 and T3 combination, then usually a trial should be done, and it should be geared to patient symptom improvement. And what the guidelines suggest is that we should use the smallest dose of T3 that actually leads to that improvement as well. In my practice, what I've done in the past is I try about a 4 to 6 month trial of T3 and T4 combination, and then I reconvene with the patients and ask them whether or not those symptoms have improved, or if we made any improvement with that at all. We monitor with TSH as well, and also free T4 levels. Most people would also monitor free T3 levels. However, this actually is less useful for me as a physician, because free T3 levels can fluctuate if you're on Cytomel. And that is because the short half-life of this leads it so that it depends as to when you do your blood work as to how high your T3 level is going to be. So it might reflect more when you took your last dose of the pill than what your normal free T3 level is going to be at the level of the cells, which is where we need to use it. So that's why I put here that serum levels don't necessarily mean that that's what's happening at the target cell. What I tend to do with Cytomel is, if I put patients on it, as long as their TSH is within the normal range, then I think I'm happy in continuing with the therapy. And this is just from a paper from 2020, where they actually looked at the concentration of T3 just to kind of make a point for that twice a day dosing. Is that, as you can see, there's an up and down concentration in the bloodstream depending as to when we measure it. And it's all dependent as to when you take your last pill. So if my cursor would work, if you take your blood work here, your T3 might show high, but if you take it later in the day, it might show lower. So that's why T3 levels don't necessarily reflect what's happening at the level of the cells, but more so when you took your last pill. And if we go back to all of the guidelines for the treatment of hypothyroidism worldwide, it is definitely standard that we do not use T3 alone for the treatment of hypothyroidism, because essentially we're just giving a whole bunch of T3 that is the active molecule that can actually have metabolic effects. So that leads to more adverse events. And when we look at combination therapy on the right, only the British and the European thyroid associations do recommend some use of that. The American guidelines don't suggest the use of combination therapy, but they do acknowledge that there's a subset of patients where this might be tried as well. And then we have desiccated thyroid extract. So this used to be the main form of thyroid hormone replacement in the early 1900s. Because again, levothyroxine and Cytomel came around in the 70s approximately. There were concerns at the time about the lack of regulation of desiccated thyroid extract, and also poor reliability in the concentration of hormones from tablet to tablet. And historically, it's been pork and bovine or cow thyroids that have been used for the extracts. Now there's actually better regulation on some of the formulations, although you can still get some non-regulated forms through compounding pharmacies throughout the country. So that can actually lead into some inconsistencies in the concentration of hormones. Desiccated thyroid extract can be an option for treatment, but it does require closer monitoring just to minimize side effects. The one from IRFA that we have available in Canada, it's actually derived from pork thyroid glands. The one thing that I should note is that pork thyroids actually have a higher ratio of T4 to T3 than human thyroid glands. So it's about a 4 to 1. So essentially, you're getting a bit more T3 for every T4 molecule than you do in regular human thyroid. What does that mean for us? So in Canada, we have 3 different doses, 30, 60, and 125 milligrams. And when we looked at desiccated thyroid extracts, they actually referred to doses as grains. So half a grain or 30 milligrams essentially is equivalent to about 50 micrograms of T4 and about 12.5 micrograms of T3. Again, I caution patients with cardiovascular disease or heart conditions, pregnancy, high blood pressure, or those with advanced age and other comorbidities about the use of desiccated thyroid extract without monitoring, because again, we do have a higher concentration of T3 that we would normally have in our own thyroid glands, let alone combination of T4 and T3 with Cytomel. So it does need to be quite monitored, and I would tend to avoid it on those with heart conditions. So is one option better than the other? So there's been previous studies trying to answer this question, and none have shown that one option is actually superior to another. So they seem to be quite equivalent. Desiccated thyroid extract actually has, in the blood work from these studies, has shown that they have higher T3 and free T3 levels on blood work compared to the combination of T4 and T3 or levothyroxine alone. But this is not unexpected because we know that the pig thyroids have a little bit of higher T3 concentration. And all three options are actually able to achieve a normal TSH level in the studies. But one thing that I do note is, usually clinical trials and studies are very well monitored settings. So, at least in those settings, we know that either option is probably safe. What do patients prefer? So this table is from the European guidelines from 2012. And those guidelines actually went and looked at several different studies that compared levothyroxine against combination therapy, so T4 and T3. So on the first 5 studies are crossover studies. So what that means essentially is they started the clinical trial and they had patients on one medication, so let's say levothyroxine for a certain amount of time, and then they switch over to a combination therapy. And at the end of the trial, they asked them which of them did they prefer. And for the most part, most of the studies do seem to have a preference for a combination therapy over levothyroxine alone. A parallel study at the bottom with about 140 patients essentially had one group on one therapy and the other group on another therapy. And it seems like those in combination therapy had a preference over levothyroxine alone. So patients do seem to prefer having a little bit of T3 in their treatment. More recently, in 2018, the American Thyroid Association website had this survey. About 12,000 respondents actually filled out the survey from them. And overall, most patients were quite dissatisfied with the treatment of hypothyroidism. So in general, on a scale of 1 to 10, the response to satisfaction was right around 5, but it could have been as low as 3. When they looked closely as to what type of treatment each respondent was on, they actually found that those who had desiccated thyroid extract had actually a higher mean satisfaction than those who were not. So a mean of about 7 on a scale of 1 to 10. And then they looked at those who were on combination therapy, so either desiccated thyroid or T3 and T4 combination, and they seemed to report less issues with weight gain, fatigue, mood, and memory. Now, this types of surveys is there's this thing called selection bias because only those who are actually interested enough to go into these websites will answer. But on the other hand, these are patients who live with hypothyroidism. So I think their opinions are actually quite important to know as well. What about safety? So there's this paper that was published just last year looking at the effectiveness and safety of levothyroxine versus desiccated thyroid versus a combination of levothyroxine and cytomel. And it was a randomized blind control trial. So essentially patients were put into 3 different groups and they were blinded. So they did not know what type of medication they were on during the trial. All of the pills looked the exact same. And the way that they did this is, they had one group on levothyroxine, one group on combination of T3 and T4, and another group on desiccated thyroid. And they actually had them take that medication for about 22 weeks. Now, the 22-week marks, each group was divided into 2, and a different formulation was given to each group so that at the end of the trial, each group at the bottom here, so we have 6 groups, had been on every single different one. So levothyroxine alone, combination, or desiccated thyroid, and they did not know at what time period they had what therapy. And then at the end of the trial, they actually had them do some questionnaires about thyroid symptoms, quality of life, depression, as well as memory. And when I look back at the memory scale, it was pretty comprehensive. They looked at auditory memory, visual memory, short and long-term memory, as well as working memory as well. So it was pretty extensive questionnaires that they used. And all of these questionnaires have actually been validated before. So it was a standardized for everybody. And they actually found no differences in whichever therapy they used as to whether or not they had any improvement in this in general. They subclassified those who had the lowest score in the cognitive measures at the beginning of the trial and looked at them at the end. And that was the group that actually had the most improvement when they had combination therapy or desiccated thyroid, at least in the cognitive realm. They did not find any adverse reactions to either medication in either group. So it was shown to be safe. But the one thing I want to mention is that this group was actually a pretty healthy group of participants. So it was people within the age of 18 and 65, and they did not have cardiac issues. So no cardiac issues, no lung issues, no kidney issues. So they were quite healthy, and they were younger, again, between 18 to 65. So at least in that patient population, it seems that either option actually works well. And then this group also asked them about the treatment preference. And as you can see in the table there, most people tended to rank either desiccated thyroid or a combination therapy as their preferred therapy of choice compared to levothyroxine alone. And I think this is important because they did not know what therapy they were taking, but they seemed to still prefer the time where they were either on some combination therapy. So in summary, hypothyroidism or underactive thyroid is a common problem in North America. Most commonly, it's due to an autoimmune destruction of the thyroid gland called Hashimoto's, and the symptoms can affect most organs in the body. And that actually is quite difficult sometimes to attribute the symptoms to thyroid disease versus another cause. We use a high TSH level and low free T4 level to diagnose hypothyroidism. And when we treat it, we actually target a normal TSH level, and that is the case across the board. Levothyroxine is the guideline recommended treatment for hypothyroidism, so that's what most people will be on. But we know with more recent trials that not all patients achieve adequate symptom improvement on just levothyroxine alone, and I think that's starting to become more and more recognized. Now, while the guidelines don't routinely recommend combination therapy, still think that a trial of T4 and T3 may lead to some symptom improvement. And at least based on the studies that I showed you, it seems that that seems to be the preference for most people. Now, I would say that elderly patients, pregnant women, and those with heart conditions should really avoid using T3 therapy just because of the risk of adverse events. If we use combination therapy such as T4 and T3 or desiccated thyroid, that can actually be done quite safely in a specific patient population. So that actually is done with close monitoring as well as frequent reassessment for the effectiveness. So if we're going to use the combination therapy, is it really working? So I went to see an endocrinologist. So hypothyroidism is quite common and it can be managed very well by family physicians alone. However, there comes times when they actually come to us as endocrinologists for further help. So every time that patients consider combination therapy, T4 or T3 or desiccated thyroid, maybe a referral to an endocrinologist may be warranted. There are family physicians who are comfortable managing combination therapies, but there are others who do not. So I think this is where the expertise might be helpful for patients. What do we do in our clinic? So I think counseling is important because if we're going to put you on a medication such as T3 or desiccated thyroid, it is important for you as a patient to be informed as to what that entails and the caveats around it, the clinical trials that have been done before. And then also we help with decision making, which therapy is good for you. And then we can walk you through and just, put you on some combination therapy and then reassess down the road to see if it's working, and that can be done in a safe manner. Patients who have other comorbidities who are thinking of going into combination therapy might be well suited to see an endocrinologist, and all pregnant women who have hypothyroidism that's difficult to control may be well suited seeing a specialist for that. And I usually recommend people who have hypothyroidism due to a pituitary deficiency or central hypothyroidism, because the pituitary gland also produces other hormones that may be affected. So this is where a specialist opinion might be handy. So that is what I had for my presentation. I want to thank again the Thyroid Foundation of Canada for giving me the opportunity to talk. And I guess we'll open it up for some questions at this time. Thank you.
Thank you very much, Dr. Franco Lopez. Harista is going to be looking at some of the questions and asking Dr. Franco Lopez on your behalf. Please remember, don't send your questions on the chat. Use the Q&A, because that's the way you're going to get answers.
I'm just going to stop sharing my screen just so I can see the.
Thank you. Great. Okay, Harista, do you want to start with the first one?
Yes, so thank you, Dr. Franco Lopez, for that excellent presentation. We actually have several questions in the Q&A, so we'll get started with the first question, and we will try to get through as many as we can. So an anonymous attendee asked, is it possible to have tongue swelling when you have no thyroid gland and are on replacement therapy? What is the treatment?
Yes, so typically for hypothyroidism or tongue swelling due to low thyroid hormone, it's actually more of the severe end of hypothyroidism when you can do it. There are other conditions that can lead to tongue swelling. So not only low thyroid function will cause it. So there's some allergic issues that can actually cause tongue swelling as well. As far as treatment for that, if we know that your thyroid function is normal, then I would probably look for alternative causes. And that's with probably a more specific, physical examination and history might be helpful. But if it is due to low thyroid hormone, it tends to be when it's been low and for a longer time for that to develop.
Right, thank you. And Dorothy asked, if someone has low TSH but normal T3 and T4 levels, should they be increasing their thyroxine dosage?
That's a good question. So if I am assuming that that is for primary hypothyroidism, that is a level of the thyroid gland, a low TSH essentially means that the body is feeling a little bit too much thyroid hormone. So in that case, it's actually decreasing the dose a little bit until that TSH level normalizes. However, if you have pituitary hypothyroidism or central hypothyroidism, then your TSH is always going to be low because, again, the pituitary gland does not produce TSH. So whenever we measure it on blood work, the TSH level is always going to be low, no matter what level of hormone we give you. So if that's the case, then we usually target the free hormone levels to make sure they're in the normal range. And then we don't necessarily worry about the TSH, only if it's a pituitary issue. If it's just primary hypothyroidism, a low TSH means that you're getting maybe a bit too much thyroid hormone, and maybe decreasing the dose might be the best thing to do.
Okay, thank you. Lawrence asked, on a similar note, what might it mean if TSH is high above lab range, but T4 is normal within lab range?
Yeah, so that is a good question. So that's actually a specific entity that we refer to as subclinical hypothyroidism. So essentially it means that, you know, your free hormones seem to be on the normal range of the blood work. However, your TSH continues to be high. And there's actually specific guidelines for the treatment of subclinical hypothyroidism. And, you know, just to summarize, essentially, if your TSH is between 5 and 10, then you only treat that if you have symptoms of hypothyroidism, or if you have positive antibodies that might suggest that you have the beginnings of Hashimoto, so anti-TPO and anti-thyroglobulin. However, if you are being treated already for hypothyroidism and your T4 and T3 are in the normal range, but your TSH is high above the normal, then that might suggest that you might need just a little bit more to kind of bring that down in the normal range. What we tend to do is, if it's just right above the upper limit of normal, then we tend to just wait it out and then repeat blood work about 4 to 6 weeks later, because we do have fluctuations of TSH levels, again, based on other factors. So if you just came up from an illness, or you have inflammation going on elsewhere, or or you were not taking your pills as consistently and maybe restarted taking them just before you took the blood work, then I might actually show a normal free T4, but your TSH might still be kind of lagging on the way down. So it will vary depending as to what the situation is.
Right. Our next question is, I would like to know the long-term effects of several years of misdiagnosed, untreated hypothyroidism, including 3 incidents of myxedema.
I see. Okay. So mixed edema refers to essentially quite severe hypothyroidism. And most of the time it's severe enough that it lands people in hospital and requires some monitoring before we treat it. So that tends to be kind of one of our endocrine emergencies that we talk about, is untreated hypothyroidism that is severe enough to affect other organs. So heart would be severely affected, kidneys, liver, etc. So long-term consequences of that, I mean, it's difficult to say because, people who actually go into mixed edema, there's not that many for us to be able to do clinical trials and kind of assess them long-term. So, however, untreated hypothyroidism has been shown to lead to issues with osteoporosis and fractures down the road. So that's one of the biggest risk factors of that. But for the most part, if there's any type of organ damage because of severe hypothyroidism, once we replace some of those hormones back, some of those changes actually kind of revert to normal as well. So it is difficult to say specifically for this person as to whether or not there will be any long-term consequences. But for the most part, when we see people in mixed edema, once you kind of replace some of those hormones and everything kind of regulates themselves, we do see some of those changes from the heart, liver, and kidneys, for example, actually revert back into a normal. So it's hard to say, but just for everybody to know, mixed edema essentially is severe hypothyroidism that leads to some sort of organ damage.
Thank you. The next question from Dorothy is, will a microadenoma of the pituitary gland cause hypothyroidism?
Okay, so microadenoma essentially means it's a little nodule on the pituitary gland, and microadenoma means that it's less than 1 centimeter. So that just basically tells us what the size is. Can that lead to hypothyroidism? So sometimes it can. Usually, the bigger the nodule in the pituitary, the higher the risk of it's going to knock down the production of some of the hormones of the pituitary, because the pituitary resides in a very tiny space called the sella. And anything that grows over 1 centimeter can actually start compressing things and then knocking down their function. So usually a microadenoma tends to be small enough, but it doesn't mean that it cannot, because if it's affecting the TSH producing cells, then it could possibly do it. So every time we see someone with a pituitary nodule, we actually run down with all of the hormones and try to establish if one of them is affected. But yes, pituitary nodules can cause hypothyroidism. It just requires a full assessment of all the hormones to see which one it's affecting.
Right. Thank you. And another question is, what can you say about incorporating iodine in one's diet?
Yes, so I mean, iodine is necessary specifically for thyroid hormone production because it's one of the substrates that we use. In Canada, that's typically through our diet, through many fruits, vegetables, and even salt. We have enough iodine for what we need. And if I remember correctly, it's between 150 to 250 micrograms and daily of iodine content that we need in our diet to be able to perform our bodily functions. So typically, at least for us, there's enough access to iodine from our diet that iodine deficiency is rarely seen in Canada. Would I say that you have to take additional iodine? Not necessarily. I think for the most part, that issue in Canada is not seen as often. Even if you don't take table salt, you probably have enough from the diet itself.
Another anonymous question. What about patients who had thyroid cancer on combination therapy? Where do you keep the TSH level?
Yeah, so for thyroid cancer, that's actually a very specific target population because in thyroid cancer, we have very specific TSH targets, and that's mostly to prevent recurrence of the thyroid cancer itself. So, it depends as to what risk of thyroid cancer. So low risk thyroid cancer, our target TSH is actually on the lower end of the normal range. So between 0.2 and about, 2. And the normal range when we see it in the blood work is between kind of 0.3 and 5 or 4, right? So we actually keep it closer to the lower end. If it's a more of an intermediate risk thyroid cancer, we actually want the TSH to be suppressed, so to be low. And for most intermediate risk thyroid cancers is between kind of 0.1 and 0.5. And for the highest risk thyroid cancers, then we actually want the TSH to be completely suppressed. And the theoretical idea there is that TSH is meant to stimulate thyroid tissue to produce hormone and grow. So in thyroid cancer, if they get surgery to remove the thyroid or radioactive iodine to kind of kill off any remnants, our purpose will be to completely suppress TSH so that there's absolutely no stimulation of any microscopic thyroid tissue that might be remaining. So it's a very specific reason why we target low TSH levels. As far as what therapy to use, most people feel comfortable with levothyroxine because the levothyroxine can actually achieve that course. I have not seen personally many thyroid cancer patients on combination therapy, but there wouldn't be a reason why they couldn't be. And as long as the TSH is within that target range and it doesn't cause any additional harm, and by that meaning cardiac issues or arrhythmias, then I think it's probably safe.
Thank you. Another question. So if you're on levothyroxine for many years and the family physician says they like the numbers from your blood test results, I guess, but the patient still reports feeling symptoms, do you have any suggestions for cases like this?
Yeah, and we see that all the time. So it's a matter of number one, knowing your patient and then trying to figure out, is the symptom that they're reporting truly due to hypothyroidism, or is there something else going on at the same time that might be clouding things as well? So the first thing that I do is I tend to say, okay, is this symptom just because of low thyroid hormone, or is there something else happening at the same time? Because the last thing that you want would be just to focus so much on your thyroid that you're missing something else that's happening. 2, if we think that this is due to low thyroid hormone and the numbers look good, Again, there is studies showing that there's a subset of patients who maybe need just a little bit of T3 in addition to the T4 to be able to feel better. And I think a conversation of having combination therapy could be had with the family physician. And if they are comfortable doing that, then that could be a short trial of about 4 to 6 months and see if the symptoms improve. If they don't feel comfortable prescribing combination therapy, then that's probably when an expert like an endocrinologist may be able to help in having some of those discussions. But essentially would be just kind of gauging, is this thyroid related? And if it's thyroid related, will a short trial of combination therapy work? And then reassess after that.
Thank you. There's a lot of activity here in the Q&A. So why don't endocrinologists prescribe LT3 or desiccated thyroid? I have to pay a very expensive functional medicine doctor to receive care.
I see. So I mean, that probably will vary from endocrinologist to endocrinologist and physicians in general as to, number one, who feels comfortable, right? So if you haven't used Cytomel or desiccated thyroid in the past and you don't feel comfortable prescribing it, so that might play a role. Number two, I think the fact that guidelines suggest just levothyroxine alone plays a big role, especially as we're training, and that is essentially what we see as the guideline direction, is we use T4 alone. And this shift into using more combination therapy might be more recent as well. So people might be used to using levothyroxine for many years, and they don't really feel like adding T4 or desiccated thyroid might be a good option. I think it's an option like that, but it would depend as to every single physician if they feel comfortable using it. So why they don't use it, there could be a myriad of reasons, but I think comfort and then using it is probably one of the biggest ones. And the fact that guidelines say that only T4 should be used, for the most part, it probably plays a role in that as well.
Thank you. So several people in the chat have been asking the difference between normal and optimal hormone values or levels.
Yeah, so I guess maybe just a technical thing, but normal levels would be what the lab would report as the normal range. And that can actually vary from lab to lab as well. I would probably say optimal might mean what TSH level leads me to have better symptom control. And that might vary from individual to individual. What I do say in general, however, to my patients is that, I know that the normal range of TSH, can vary quite a bit. What I don't want to see is your TSH being too low or too high. So as long as I have you within the normal range, I think I have some leeway to play around there without necessarily getting you into trouble by having too much or too little thyroid hormones.
Right. And Juliet asked, besides soy, what other food items should be avoided by hypothyroid patients?
I usually don't have much of a discussion with my hypothyroid patients at what foods to avoid. So, I usually don't tell them to avoid anything, to be perfectly honest. I usually have a conversation about as to timing of when to take their levothyroxine. So if you have cereal in the morning and taking it with milk, so there's a lot of calcium there that might affect its absorption. So having it in an empty stomach is usually what I tell them. And then other medications that might affect its absorption. So calcium, iron supplements, like I mentioned, there's always proton pump inhibitors. So things that are used to treat acid reflux, because that affects the acidity of the stomach, and then the absorption actually might be affected as well. But I personally don't have much discussion on what diet things to avoid. I usually just talk about more of the timing of the thyroid hormone. So I won't be able to answer that question.
Thank you. Anne asked, is there a formula for dosage based on patient's weight? How do physicians decide on an optimal dosage?
Mm-hmm. Yeah, so there is. So if we assume that your thyroid is no longer producing any hormone or just very little hormone, then we use the weight, and the formula is 1.6 micrograms per kilogram of body weight, and that's what we typically say as your dose should be based on your weight. But it is not a perfect formula. Sometimes it could be 1.6 micrograms per kilograms of lean body weight. So that might change from individual to individual. And there are some physicians that we can just start with a slow dose of 25 or 50 micrograms if your TSH level is not too far off from the normal range. So But if we use body weight as 1.6 micrograms per kilogram, is what we typically use as the full dose.
Okay, thank you. And Tracy asked, where does Addison's fit into hypopituitarism?
So Addison's disease refers to adrenal insufficiency. That means that your adrenal glands are not producing enough cortisol. Hypopituitarism refers to something else. So that means that your pituitary gland is not producing any of the hormones, one of which is the precursor or the stimulant for cortisol production called ACTH. So typically, Addison's refers to a problem at the adrenal glands, not at the pituitary, and hypopituitarism refers to a problem at the pituitary, but typically the adrenal glands are working. So I would probably say that those two things are different, so two different diseases. But you can have adrenal insufficiency or low cortisol levels because of a problem at the adrenal gland, but you can also have a problem at the pituitary gland, just like we have in thyroid, so primary and central. But I would say those two things would be different based on how that question was asked.
Thank you. Sharon asked, is thyroidectomy related to peripheral neuropathy?
Sorry, could you repeat that question?
Is thyroidectomy related to peripheral neuropathy?
So sometimes people can have tingling or carpal tunnel syndrome from hypothyroidism. Not necessarily think it's due to neuropathy per se. So neuropathy refers to a nerve damage. In hypothyroidism, sometimes is due to swelling or increase in tissue swelling. So in carpal tunnel, you get a lot of swelling on your wrist, and that's what causes some of the compression of the nerve, the median nerve that goes in the middle. But I have not heard of neuropathy per se happening in my patients with hypothyroidism.
Okay, thank you. Is suppressed TSH normal when taking ERFA?
I would say no. So if we're going to take ERFA desiccated thyroid, then we actually always try to target a TSH within the normal range. So if the TSH is suppressed or completely undetectable, then we're giving too much of that of hormone, either be T4 or T3, and that would be an indication to back down and then keep it in the normal range. The reason why we care for that is if you have completely suppressed TSH levels for too long, that's essentially your body telling you you have too much thyroid hormone in the bloodstream, and then that can put you at higher risk of arrhythmias or irregular heartbeat, also higher risk of osteoporosis. And that can also lead to symptoms of hyperthyroidism or too much thyroid hormone. So, you can go from constipated to now having very frequent loose bowel movements. You can start getting palpitations, you can get tremors, you can become quite sweaty. That can affect your sleep. So sometimes people say, you know what, I can't sleep because I'm hypothyroid, but you can also, not be able to sleep because you're hyperthyroid. And that can also affect your concentration if you're getting too much thyroid hormones. So it's, if the TSH is completely suppressed, then I would say you have too much of it and maybe a decrease in the dose may be warranted.
Thank you.
Lisa, can we do another 5 minutes of questions and then we'll,
Yeah, I was going to ask, there's a ton of questions still coming in, so we're just going to take a few more and then we'll be done. So family practitioners don't feel empowered to prescribe combination therapy. Some even told me that they would get in trouble with the College of Physicians for doing so. Why is this?
So I think comfort is one thing, and experience using combination therapy. As far as getting in trouble with the college, that I will not be able to comment. It will depend as to what province they're practicing and all of that. So it's difficult for me to comment on that. But I think comfort is a big thing. There are medications that myself as an endocrinologist don't feel comfortable prescribing because they're not within my specialty. So I think it's completely reasonable if they don't feel comfortable, for them to avoid prescribing it, because I think before we do anything else, we have to make sure that we do something that is safe. So I think that's probably the biggest reason, is lack of comfort or experience using these combination therapies. And that would be where a referral to an endocrinologist might help. But I won't be able to comment on issues with the college because that varies from province to province. So.
Right. Another question, can a vitamin D deficiency or iron deficiency have an effect on thyroid function?
So not necessarily on thyroid function per se, but they do have similar symptoms. So vitamin D deficiency essentially can lead to osteoporosis or issues with calcium regulation as well. And sometimes the reason for why people are vitamin D deficient can also play a role into how thyroid hormone is regulated, because sometimes people have malabsorption issues where they don't absorb things as well through the gut. And then iron deficiency just causes very similar symptoms that hypothyroidism. So people feel very fatigued, they start losing hair, they feel really cold. So, you know, sometimes it can be like in the differential diagnosis. So when we think of what could cause the symptoms, iron deficiency and hypothyroidism actually go hand in hand. So they cause similar symptoms, but I wouldn't say that one can lead to the other.
Right. I think maybe we'll take one last question last, if you agree. Yeah, okay. So how can we approach or talk to our doctors about the benefits of combination therapy?
Yeah, I mean, I think it's, you know, as a patient, you know, sometimes we have to be our own advocates. So I think it's having a good, sincere discussion that maybe single therapy, it's not working as well. And that, you know, there is data saying that combination therapy can work safely for a specific set of people if it's done well. So one of the things is the last thing that you want is for you to go on combination therapy and not be monitored ever, because that's when, you know, actually things can happen, things can go wrong. So I think that's one thing is that, you know, it is something that it's discussed in the literature, and I guess it has to do with the rapport that you have with the patient. So it's difficult to say, but based on the relationship you have with your physician, you can actually say, you know what, I don't feel well on levothyroxine alone. Am I able to do combination therapy? And if that physician is not comfortable, then maybe trying to suggest a referral to an endocrinologist that might have a little bit more experience.
Thank you. I guess that was a great question to end off the Q&A.
That was a perfect question for ending it. Thank you very much, Anista. I'd like to thank Dr. Franco Lopez for giving us this presentation on hypothyroidism and thyroid replacement therapy. I would also like to thank our webinar team for making this educational event a success. I'd like to mention, if you have some spare time and you would like to volunteer to help others with thyroid disease virtually from your home, please call us on our helpline at 1-800-267-8822 or email us at info@thyroid.ca. You can also assist us by becoming a member or making a donation by visiting our website at thyroid.ca. As you exit the session, please take a moment to complete our short survey. It will help us improve future webinars. Our next webinar will be on April the 24th. Dr. Kelsey Rolfs will be speaking on thyroid eye disease. Please mark your calendars for this interesting presentation. All of us at the Thyroid Foundation of Canada hope to see you at our next webinar. We hope that you and your families are well and keeping safe. Thank you. Thank you, everyone.
Okay, thanks for having me.
Thank you. Thank you,
Bye-bye.
Dr. Franco Lopez. And this presentation will be available on our website in 2 or 3 days.